Good afternoon, everybody. I would like to welcome all of you to our practical workshop on transcutaneous CO2 monitoring with a specific focus of mechanical ventilation. And honestly speaking, I'm really happy that we can do this symposium now for the second time. We did so last year at the ERS conference. And many thanks to SenTec that we got again the opportunity to run this symposium on transcutaneous CO2 monitoring. These are my presenter disclosures, lecture fees, and the hospital does also receive some open research grants as displayed here. And I will just starting giving you an impression on the agenda. So I will just start with a very short introduction lasting a couple of minutes, and then I will directly hand over to the colleagues from SenTec because we have prepared practical demonstrations, which is in my view really necessary and also important and very, very worthwhile. Then we will switch to clinical presentations, and it's Dr. Lobato and me chairing this session scientifically. So both of us, we will focus on chronic respiratory failure and acute respiratory failure respectively. And this will be followed by workstations. And of course, as this is a workshop, you will have the time to contact us, to raise your questions all of the time. So don't be shy, don't hesitate, come to us and raise your hands and raise your questions. Well, just to start with, when we talk about CO2 monitoring, it is essential to acknowledge what the specific scenario is. And here we have to consider the respiratory system consisting of two different parts, which can be independently impaired from each other. One is the lungs, and one is the respiratory pump. In case of pulmonary failure, we have evidence of hypoxemic respiratory failure without hypercapnia. So hypercapnia is almost a part for respiratory pump failure when alveolar ventilation is reduced in this scenario. And here we need to go for mechanical ventilation or for artificially increasing the amount of alveolar ventilation. So in general, we do have a couple of measurement tools available. It is, for example, arterial blood gas analysis, PaCO2. PaCO2 could also be measured using the arterialis capillary blood gas analysis. We could go also for venous blood gas analysis, and then transcutaneous CO2 monitoring. That'll be the topic for today. And I will also talk a little bit of end-tidal PCO2 monitoring. So overall, the current thinking might be that we have one technique which is best. However, the truth is that that we have certain advantages and certain disadvantages for different measurement techniques respectively. And of course, as the arterial blood gas analysis is the most accurate one, this is still the gold standard or regarded as the gold standard measurement tool. And of course, all other measurements need to be compared against arterial blood gas analysis. But considering different criteria, that is continuous monitoring, non-invasive monitoring, painless monitoring, or technical issues, or being dependent or independent from artificial airways and all the other stuff you can read here, you have certain advantages and disadvantages for different measurements. So we do not have time to go through all this. However, I can just give you some ideas on what transcutaneous CO2 monitoring does. So in the ICU setting, of course, we need to be as accurate as possible. Therefore, the ABG is still the most important issue. But transcutaneous CO2 monitoring has the clear advantage as it is perfectly valid for chronic respiratory failure. It is also perfectly fitting with the application of non-invasive ventilation, so non-invasive measurements, non-invasive ventilation. It's also true for screening of nocturnal alveolar hyperventilation or looking for sedation procedures like during bronchoscopy or other endoscopic procedures, and those patients being at risk for hyperventilation. So this is just an impression, just an example how important continuous monitoring is. And this is a patient from a study originally. It is a 34-year-old patient with congenital central hyperventilation syndrome. And you can see that because of the study, we used 3 different technical devices to measure CO2 transcutaneously. And we also used arterial blood gas analysis 4 times. But consider a clinical scenario you might think about blood gas analysis done exclusively, for example, in the early morning and also in the evening. And in this scenario, you probably agree that we would definitely have missed to detect severe hyperventilation despite the application of non-invasive ventilation. You can see the CO2 values, they go up and they go down, probably depending on leakages, probably depending on sleep stages. And this is not visible and detectable if you don't go for continuous monitoring, what technique ever is being used in this scenario. Well, and this is another example, a very nice example in my view, of a 49-year-old patient with amyotrophic lateral sclerosis. You can see without mechanical ventilation, the patient is severely hypercapnic. He went to sleep, and according to the CO2 values rose up overnight. And even though it is not displayed here in the sleep lab, obviously the students also discovered oxygenation to be dropping. And what they did apply oxygen. This is really funny, actually. If you can see what is going to happen is here that there was a sudden and a huge increase in the pCO2 value as transcutaneously measured. So they also realized that something is wrong. They removed the oxygen, but as if they haven't believed what is going to happen, they tried it a second one. So even as if they hadn't believed what physiology is, but unfortunately physiology has to document what it has to document, that is an increase in pCO2 in case of oxygen being given in a patient with pure hyperventilation. So in the end, only non-invasive ventilation was shown to be capable of sustainingly reducing pCO2 values overnight. And again, it is important to make the point here that we need to go for a continuous monitoring to have a clear picture of what is going on overnight. So this is just my starting point, and from now on I would like to hand over to SenTec colleagues, and we want to start with the live demonstrations. Thank you very much.
Thank you. Can you switch on, please? Okay. Thank you, Professor Windisch. Dear ladies and gentlemen, thank you for coming and joining our workshop. My name is Martin, and I will be your moderator for the practical part of the workshop. With me, we have my colleague Sina, Soren, Fabian, Chelsea, Thomas, and Konrad. What we would like to show you is how to choose a measurement site, how to attach the sensor, and how the monitor works, because that is what really matters at the end. So first of all, what we need to do is we need to check that our monitor is ready for use. There's only two messages displayed on the monitor, with either calibration in progress or ready for use. So if you see calibration in progress, just wait for a second or a couple minutes until you see the ready for use display. Once the monitor is ready for use, we need to choose an appropriate measurement site. And there's different clinical validated measurement sites available. To help you there, we also have provided quick reference guides, which shows you where you can position the sensor. Just an example would be the forehead, the cheek, or the earlobe. Chelsea will now demonstrate how to position the sensor on the earlobe. So what we need to do first is cleaning and disinfecting the earlobe. We recommend using an alcohol wipe. Once we have cleaned and disinfected, let the measurement site dry. Take out the sensor from the docking station and click the sensor into the ear clip. Remove the security flaps from the ear clip, and then we need to put 1 drop of contact gel on the sensor. The contact gel is needed in order to provide a tight system to seal the measurement site against ambient air, that no ambient air is sneaking in and may cause false measurement. So once we have put the gel on, just pull on the earlobe. That we need to avoid wrinkles. So pull on the earlobe and attach the ring. And we always recommend to do 1 or 2 lobes with the cable around the ear, that the sensor stays in place and is secured. Additionally, we recommend to use a tape put that on the cheek. Perfect. So this is one measurement site, and you can do both. You could place the sensor behind the earlobe or in front of the earlobe. Both positions are possible, whatever the patient is more comfortable with. The second measurement site we want to show you is the cheek, because there we need to have an attachment ring. So we do the same process, cleaning the measurement site, let the measurement site dry, and then attach the ring. There's a specific multi-site attachment ring, which also can be used on the shoulder or subclavicular. Make sure this ring sits tight, that no air can sneak in. Also then, using the contact gel, put one droplet on the sensor and attach the sensor, or snap the sensor into the measurement ring or the attachment ring. Perfect. Turning the sensor helps to distribute the gel, that you will all have gel all over your measurement site. Thank you, Chelsea. If we now have a closer look at our monitor, we can see that there's already an SpO2 measurement and a pulse rate measurement, but CO2 is not yet stable. We can see a gray number, and we see also the message on the down that CO2 is stabilizing. Why do we stabilize? Why do we need to stabilize? The measurement principle, though, what we do, we heat up the local temperature in order to increase the perfusion, the local perfusion. Based on a higher local perfusion, we have a better diffusion of CO2 into ambient air. And the diffused CO2 is the CO2 we collect into the sensor, and based on that, we can measure the arterial CO2, or an estimation of the arterial CO2. Stabilization takes some time, between 2 up to 7 minutes, depends always on the clinical situation and always on patient. However, we do not want to wait until we have stabilized that. So we have prepared my colleagues Sorin and Fabian, and as you can see on the monitors of Fabian, the measurement has already been stabilized. So we have a continuous CO2 reading, we have a continuous trend, so it really is a non-invasive, continuous live measurement. And in order to show you how the measurement works and how fast the system reacts, I would like to ask Fabian that he will start rebriefing CO2 in the back. And before, Fabian, just wait a second. Before he starts, I would like to count the time to see how fast it really is. Okay, you can start. For sure, there is a physiological delay once the hyperventilation or the hypoventilation occurs in the lung, until we can measure that in the area where you have positioned the sensor. So the change should occur within 30 to 60 seconds. So let's see on the monitor. So it still takes some time, but hopefully it will increase soon. So we started with 36.9. So now we CO2 increases. So we will see over the next seconds and minutes that CO2 will further increase. It took us 34 seconds. I think that's pretty far, isn't it? Okay. So Fabian, I think you can stop rebriefing because we do not want to ventilate you later. Okay. If we switch over to Sorin, because what also happens in clinical practice is that patients are hyperventilating. We also would like to show you how fast that works. Sorin, could you please start hyperventilating? Sorin, just a second. I forgot something which is important, but no problem, we can continue. And we can set a reference point on the monitor. So Chelsea will show us how to set the reference point. And the reference point is called at SenTec a baseline. Why there is a reference point needed? It just shows that what is the difference, so we can look at the... Could you more zoom in, please, to the monitor? Here, so you can see the white line here. So we we will have a horizontal and a vertical white line there, which shows that what was the reference point. We could have the reference point for 10 minutes, half an hour, or even longer. It just shows that what is the change. Basically, if we do an adaptation of the ventilator settings, and we then can see in 24 hours later, what was my change? Did that work or not? Okay. So, Sorin, I think you can stop hyperventilating. We already can see on the monitor there was a really nice drop of the CO2, and it still continues. There is a small time delay, and then we have a number displayed here. This is called the delta 10. The delta 10 gives you the change of CO2 within the last 10 minutes. It's also a helpful tool to see what happened with my patient. Okay, so I would like to ask our clinical expert a question. So, Dr. Lobato, how important is the fast reaction time of transcutaneous monitor in an acute setting?
From a clinical point of view, this is a very important issue because the clinical condition of the acute patient can change fast in the time. So to have a device that is able to inform us in a brief period of time the clinical condition of the patient has changing, allow us to take a decision to solution the problem that the patient have.
Okay, thank you. Can you switch on my mic? Is it on again? Okay. No? So Dr. Windisch, what is your feedback on that?
I mean, of course, it is the reaction time is suggested to me much more important for the acute state than for the chronic state. However, if you consider, for example, different sleep stages or mask problems overnight, so the more reactive the system is, the more clear would be the picture in the end. So sometimes you have sleep-related hyperventilation during specific conditions like sleep stages, REM sleep, for example. So it would be very helpful to have a very fast reacting system for transcutaneous CO2 monitoring. But of course, in acute medicine, it's much more important.
Okay, perfect. Thank you. So just a question. Did you stop breathing before? Did you saw that his saturation dropped?
Yeah.
And that there was an alarm? So I think he stopped breathing. Oh. Yeah. Perfect. Thank you. So I would like now to hand over to Professor Windisch for the clinical presentations. But please take the opportunity, come later to our workstations and experience CO2 your own.
I will start with an overview over the chronic part, chronic respiratory failure. Again, my presenter disclosures. And, you know, actually, I like personal case presentations because individual case presentations, you can learn a lot of it. And this is also a patient derived from a scientific trial where we directly compared end-tidal and transcutaneous CO2 monitoring, so both non-invasive techniques for continuous CO2 monitoring in patients with prolonged weaning. And this is a patient with a more restrictive pattern, a more restricted disease. And this is a patient with COPD. In green, end-tidal CO2 values are given, and in blue, you have transcutaneous CO2 values. And we have 3 spot measurements of atrial blood gas measurements. So you can easily see that in a patient with restrictive disease. So probably this patient does not have ventilation perfusion mismatching. Actually, both values, both curves are more or less comparable, even though a small difference is visible here. However, if we go to a patient in whom severe ventilation perfusion mismatching must be adopted, you can see that transcutaneous CO2 monitoring is superior over end-tidal CO2 monitoring, as the fitting with the arterial measurements is only perfectly seen here with the transcutaneous curve. So in the end, what all these studies do is they go for so-called Blanton-Altman analysis. So this is what is needed if you compare different techniques. If you, let's say, compare transcutaneous CO2 monitoring with the gold standard of the ABG, that is atrial PCO2. And basically, what you receive in the end is 2 values. The first is the bias, and this is the difference between, the average difference between the two. And for transcutaneous CO2 monitoring in this trial, you can see that the difference was 0. So on average, transcutaneous CO2 monitoring perfectly fitted the arterial values. If we go to end-tidal CO2 monitoring, you can see that this is 0 and this is the average. So by nearly 6 millimeters of mercury, the real CO2 was underestimated by end-tidal CO2 monitoring. This is the first information you get from blend and Altman analysis. The second one is the distribution of values. So this is a 95% confidence interval, so the so-called lower and upper limits of agreement. And you can also see that the more narrow this blue line is, the better the distribution is. So again, for transcutaneous CO2 monitoring, you have a more narrow distribution and therefore superiority in terms of the comparison against the gold standard. So and this is research we did a couple of years ago in patients receiving non-invasive ventilation. We did also include different techniques for non-invasive transcutaneous CO2 monitoring, the SenTec monitors, the TINA and the TOSCA. And you can see that we have two different values here, the so-called drift uncorrected values, and later on we have also to discuss a little bit of the technical drift in the recent versions we had for transcutaneous CO2 monitoring. Again, if you look at the mean difference, 1, -1, or nearly 1 is perfectly in the middle, and we can say this is clinically acceptable. However, if we go to the limits of agreement, -5 to 6.7, this is a little bit different. We can say this is perfectly within the limits of within the clinically acceptable range, and this further improves if we retrospectively do correct for the drift, and I will show some issues on this later on. So we have a very recent systemic review and meta-analysis on transcutaneous CO2 monitoring. Actually, the first message out of this study is that yes, transcutaneous CO2 monitoring is currently being used in clinical trials. So you can see there had been more than 400 trials identified in which transcutaneous CO2 monitoring has been used, and out of this, 73 had been elected in the end, where clearly defined comparisons had been performed against the gold standard of arterial blood gas measurements. So 73 studies with a summary of 2,817 participants with 7,021 paired measurements overall. So, of course, we cannot go into the details. However, what we can see here is, again, the bias. The bias surrounds the 0, surrounds null. Again, on average, we can see that transcutaneous CO monitoring across all the studies perfectly fits with the arterial measurements. However, if we go to the upper and lower limits of agreement, the scenario is a little bit different. You can see overall, and -7.5 to +7.5 is generally accepted as a clinically acceptable range, just for you to know, even though nobody knows exactly, of course. However, you can see that sometimes you have values above and sometimes you have values below. And I would just point on some important issues. One is the sensor temperature. So the limits of agreement are much more narrow if the temperature is at least 42 degrees or even higher. And it's also clear that in a chronic state where you don't give catecholamines or where you don't have septic conditions with the perfusion of the skin, of course, values are much more narrow. And therefore, we could not exclusively add one result of this meta-analysis, but just to learn that we need to consider the different clinical and technical conditions being applied in the specific scenario we are talking about. So again, another case study. This is a patient with COPD and obesity being established on non-invasive ventilation. The PCO2 in the beginning was 65 millimeters of mercury. And now you can see that the blue measurements for transcutaneous CO2 are the real measurements. And afterwards, after having calibrated the system afterwards, we could go for a correction of the technical drift. So the green line is actually what the best values are. As this was a scientific scenario, we went for, 25 blood gas analysis during a 4-hour period. And you can see that actually what was going to happen, that is positioning or changing interfaces or upper airway obstruction, directly translated into clinical changes of transcutaneous CO2. For example, the patient at the beginning was in the supine position, and during the supine position actually nothing happened, and if the patient went to the lateral position, CO2 values were about to drop, but in the end the patient changed again to the supine position and PCO2 values went up again. And then during the further course we changed the interface from the nasal to the full face mask, which was quite successful. But here, the patient was so exhausted from more the chronic hypercapnic respiratory failure that he went asleep. And after the end, after a couple of minutes or an hour or something, there was upper airway obstruction during sleeping, and therefore we had to combine a full face mask and the lateral position in order to get the patients acclimatized to non-invasive ventilation with a documented success in terms of getting the CO2 values reduced. So this is again what we have seen before, the Bland and Altman graphs, and you can see that if we go for drift, if we look at the uncorrected drift values are much more negative compared to drift correction, where the values come close to each other within the clinically acceptable range. So we used also transcutaneous CO2 monitoring as an outcome in a study where we randomly compared pressure support ventilation and target volume ventilation in this study. And again, I do not want to go into the details of the study aims, but just to show that transcutaneous CO2 monitoring was capable of detecting differences in alveolar ventilation as evidenced by transcutaneous CO2. So this difference was quite significant and also substantial, even though this did not directly translate into an improved sleep quality or improved quality of life after a couple of weeks. However, this was also repeated by another study, and you can see again that transcutaneous monitoring revealed this different results in terms of different techniques being used during non-invasive ventilation, again in favor of volume targeting ventilation. In this scenario, however, ventilation was given too much, obviously, as sleep quality had a clear trend for deteriorations in case of target volume being given. So again, I just want to make the point, if you compare different techniques, transcutaneous monitoring is capable of detecting these differences. Well, and this is the most recent study, or the best study I would guess, in obesity, hyperventilation syndrome, and transcutaneous CO monitoring, where the transcutaneous monitoring served as the primary outcome. And now, as individual adjustments were performed, aimed at achieving the control of nocturnal hyperventilation while abolishing events, in the end, in this study, no differences were evident anymore, as shown by this study. And we did also a study on the high intensity versus target volume ventilation in COPD patients. And high intensity in COPD, you can see we used pressures around 26 centimeters of water, and for target volume ventilation, the ventilator was allowed to go up and down. And the main result was that on average, there was no difference. But if you look at individual cases, some patients showed deteriorations, some patients showed improvements, and the message is that in case of being unsuccessful in a specific patient, you can just switch to the other mode, and this can be reliably monitored by transcutaneous CO2 monitoring. And this is just coming to the end of my talk, just to give an impression of our German guidelines, for which we had also prepared an international translation published in Respiration last year, just to show that for COPD, for neuromuscular patients, but also for obesity, hyperventilation syndrome, and also for restrictive thoracic diseases, we have embedded transcutaneous monitoring as an adjunct, as a tool for guiding the indication of long-term non-invasive ventilation, saying that if you have an increase by more than 10 millimeters of mercury for transcutaneous CO monitoring, we would at least consider non-invasive ventilation in this scenario, and this is true for different case diseases. So I'd like also to point on the Dutch group. The Dutch group, you may know, is very eager in doing outpatient establishment of home mechanical ventilation, outpatient control. They do a great job. And what they did is in that study that they used transcutaneous monitoring in the home environment. And it's clear if we go outside the hospital, we need to be as non-invasive as possible. And you can see that mechanical ventilation was quite successful considering the drop in transcutaneously measured CO2 volumes, and this was true for both the home group and the group of patients treated in a hospital. And this is also data from our group showing outpatient control, and this is the flow chart and our setup we have in our center. So we do also a lot of outpatient control of non-invasive ventilation in COPD. And if we do have major criteria in accordance to the data given here, then we go for prompt hospitalization. But if we have minor criteria, we try daytime mechanical ventilation and try how PCO2 as transcutaneously measured reacts in order to decide if we need to get for hospitalization or if we don't. So this is the end of chronic respiratory failure. And we have decided just to have a couple of questions afterwards, so I would directly hand over to you to cover the acute part so that we will have a discussion round directly afterwards, if that is okay for you. Thank you very much.
Good morning. First of all, I would like to thank SenTec for inviting me and giving me the opportunity to be here talking about the role of transcutaneous CO2 monitoring in patients with acute respiratory failure. You can see here my conflict of interest, and I would like to highlight that I have recently left my work at the hospital. I am currently working as a medical director in Nippon Gas Healthcare. This company focus mainly, but not only, in respiratory home care. Let me start talking a little about how do we manage a patient with acute respiratory failure. What we do with this kind of patients at a hospital. No? When a patient with acute respiratory failure or acute and chronic respiratory failure goes to the emergency department, we have to perform first a basal clinical evaluation, and this evaluation has to take into account several aspects, but more important, the level of consciousness using the Glasgow Coma Scale or something like that, and an estimation of the work breathing of the patient. We need to monitor closely the respiratory rate, as you know. We also have to perform in arterial blood gases. We have to pay special attention to the pH and the PCO2 in order to detect the existence of acidosis, any kind of acidosis, and the level of hypercapnia the patient has. Typically, most of these patients are going to be treated with any kind of respiratory support. Historically, non-invasive ventilation has been considered the gold standard to treat patients with acute respiratory failure, but lately, high-flow nasal cannula therapy has become more important and is being used more and more frequently to treat patients with non-invasive, with acute respiratory failure as an alternative to non-invasive ventilation. Current guidelines recommend us we have to perform a new patient evaluation after the first hour of starting the therapy. So we have to check again the level of consciousness, the respiratory rate, the pH, the PCO2, and when the patient presents any improvement in any of these parameters, we can think that the patient is going well. This allows us to continue a non-invasive therapeutic approach to the patient, but also a closer monitoring, specifically clinical and gasometric monitoring during the next 24-48 hours. In the last year, we have incorporated to this protocol of actuation transcutaneous CO2 as a way to monitor the patient during this period of the more acute phase of the acute respiratory failure of the patient. What I am going to do now is to try to explain you what are the reasons for change our protocol management of this kind of patient. Here at the top of the slide, you can see data from this paper that Professor Windisch has shown you before, published 5 years ago, and what you can see is the arterial blood gas was the most common technique used to monitor CO2 in acute scenarios, in a patient with acute respiratory failure, in emergency department, or the ICU areas. However, very recently has been published this paper in Thorax about the accuracy and precision of transcutaneous CO2 monitoring, and this systematic review and meta-analysis has incorporated a number of papers with positive results favoring the use of transcutaneous CO2 monitoring in patients with acute respiratory failure in the environment of the critical care areas at the hospital. All you know, the monitored CO2 is essential in patients with acute respiratory failure. It is often necessary to monitor change over time rather than just a one-off measurement of the PCO2. The current gold standard of measuring PCO2 is arterial blood gases, or agree with this, but we all agree that this is invasive and is associated with complications. To avoid frequent arterial puncture, arterial lines are usually sometimes places, but or you know, these are required to treat the patient at a higher level of care, and also is associated with significant risk. So transcutaneous CO2 is a reliable and feasible technique to monitor CO2 in this patient, and the most important concept that we have to keep in mind is the transcutaneous CO2 is a very useful technique, a good approach to monitoring trends in CO2, rather than just one measure of PCO2 in the patient. Transcutaneous PCO2 may help us to prevent complications in different scenarios. From a point of view of the CO2 surveillance, transcutaneous CO2 can be very useful to monitor patients at risk or present or develop hypercapnia. In patients, hypercapnic patients, we are going to treat with high flow nasal cannula. In a couple of minutes, I explain this with more detail. In patients that receive combined therapy, what we call combined therapy is to say patient on non-invasive ventilation, but we give the patient resting periods through using high-flow therapy, and also to monitor monitoring procedures. Here you can see, for example, a patient undergoing a bronchoscopy, an extended duration of the intervention can aggravate respiratory acidosis in the kind of patient, and the transcutaneous CO2 can advise us what is happening to the patient. So transcutaneous CO2 monitoring is reliable, is helpful, permit to assess the dynamic process of worsening hypercapnia. From other point of view, transcutaneous CO2 also can allow us to monitor more strictly the therapy. We can change the parameters on the ventilator. We can detect problems of hypoventilation during non-invasive ventilation, not only in the chronic setting, but also in the acute setting. Here you can see a picture for a patient with COPD exacerbation, and you can see first a very important thing is the good correlation between the PCO2 obtained by arterial blood gas sample and the PCO2 obtained by the transcutaneous technique. But the most important thing you have to keep in mind is that we can analyze the trend, the CO2 trend, so we can keep calm, seeing that the patient is improving clinically and seeing in the monitor this trend of CO2 lowering and lowering more and more. This is another picture. You can see a patient with acute cardiopulmonary edema, and once again we can see a good correlation between the PCO2, the arterial PCO2, and the transcutaneous CO2, and once again we can see the trends of CO2, and we can relax seeing that the patient is going well from a clinical point of view, and moreover we can see in the monitor this kind of trends. A clear indication in our hospital to monitor with transcutaneous CO2 are hypercapnic patients we treat with high-flow therapy. High-flow therapy has less evidence in the time compared to non-invasive ventilation, so we are more aware to detect problems and to check the patient is going well. high flow therapy, as you know, is efficacy therapy, but more comfortable and better tolerated by the patient compared to non-invasive ventilation. And as I've said before, is using more and more frequently at a hospital in the acute setting. We can use transcutaneous CO2 monitoring in patients in the earliest stage of the acute respiratory failure. In patients we do not intubate or in patients when we are looking for more comfort of the patient rather than a stricter control of the PCO2. And there is a field very important is the patient. We should be treated with non-invasive ventilation where we can do it. If we can do it because there is a contraindication to non-invasive ventilation, for example, a thing in a vomiting patient, or patient that do not tolerate non-invasive ventilation, or simply the patient doesn't want receive non-invasive ventilation, probably because the patient had a prior bad experience with the ventilation. And in other circumstances, we start treating with non-invasive ventilation a patient, but the ventilation fails. If the patient do not intubated orders, or the patient have no criteria for intubation, using high flow therapy is a good alternative to treat this kind of patient, and transcutaneous CO2 permit to have a more relaxed approach to the clinical patients. And I have said before, also the combined therapy, non-invasive ventilation, alternative is high flow therapy in the resting periods can be another kind of patient, kind of situation. Transcutaneous CO2 can be very useful for us. This is my last slide. Here I would like to show you this data from this table published in the European Respiratory Review last year about how should we monitor patients with acute respiratory failure treated with non-invasive ventilation. And as a summary, in patients with mild respiratory failure who are going to be treated in the general ward, probably it's not necessary to use transcutaneous CO2 monitoring, but in more severe forms of acute respiratory failure, or patients who are going to be treated in most specific units like intermediate care, respiratory care units, high dependency units, intensive care units, or something like that, probably is a clear indication to monitor the patients with transcutaneous CO2, avoiding them several arterial punctures during this acute phase of the therapy of the acute respiratory failure. Thank you very much for your attention.
Thank you for your participation.